Hello, welcome to the part 2 of antepartum hemorrhage. This is week 4 of one topic a week series. So starting with placental abruption. We have done previa, now we'll discuss abruption. So what is, first of all, again revise what is the definition of antepartum hemorrhage. Antepartum hemorrhage hota hai bleeding from the genital tract from the period of viability, which is 28 weeks in our country, till delivery. That is called as antepartum hemorrhage. One of the very common causes are previa, placenta previa and placental abruption. Placenta previa होता है that the placenta is in lower segment. Previa का मतलब है lower segment. So when placenta is in lower segment is thin. Generally, sometimes there is disruption of some of the spiral arterioles. जो maternal spiral arterioles हैं उनका disruption हो जाता है resulting in bleeding. Placental abruption is a different pathology and I must say a severe pathology. Placental abruption is bleeding from a normally situated placenta. This placenta is situated normally. So placenta is normally situated, but due to certain conditions, the placenta gets disimplanted from the site where it is on the endometrium. So जिस जगह पे वो endometrium पे implanted होती है, it gets disrupted, resulting in bleeding. Now it is of two types. Bleeding can be concealed, it can be revealed. Concealed मतलब छुपी हुई, hidden. So bleeding which is concealed like this one, can you see this one? That placenta has disrupted from its original place, it has disimplanted and the bleeding is getting collected behind it only. Retroplacentally blood collect हो रहा है. So it is very dangerous. Why? Because you can't see anything coming outside. Patient को पता ही नहीं है कुछ हुआ है. Patient will not come to you. There will be no bleeding. So there will be no bleeding coming outside of the genital tract, but bleeding will keep on collecting here. And so much pressure is created behind placenta that it will shear off further more placenta. वो दूसरी parts को भी shear off करती जाएगी because of this pressure retroplacentally. So this is concealed. One is revealed when there is disruption but the blood comes out. So it is visible. First, it will get noticed early and it can be treated. Second, there will be not that much retroplacental pressure. यहाँ पे pressure will not be that much. So it is less dangerous. Okay? Now the question comes, whose blood is there when the abruption happens? Because abruption is a very severe condition. So basically the disruption of what happens, what I've told you, is of the spiral arterioles. Can you see the spiral arterioles? This is the whole placenta. Can you see umbilical cord? This is the umbilical arteries, umbilical vein. So obviously this is our fetal side. Whereas this one is our maternal side. Okay? इधर से maternal blood supply आ रही है. In form of these, can you see these thin spiral arterioles? These are maternal arterioles. When they get disrupted, it results in abruption, resulting in blood clot collection here. So it is basically the maternal blood which is getting collected here. But what will happen? It will detach the whole of the placenta. Whole of the placenta will detach and the blood supply to the baby will cut off. So baby will become hypoxic because now the baby is not getting enough blood supply. Okay? What are the risk factors? You can divide risk factors into maternal, fetal and behavior. So maternal risk factors are if there is again high age, then if the mother is hypertensive, if the mother has preeclampsia. So you know in preeclampsia, the invasion, the second wave of invasion does not happen. Invasion किस में? Inside the spiral arterioles. So this invasion is improper because of which preeclampsia happens. So when this invasion is improper, that is one of the cause that the spiral arterioles might disrupt. They might not be able to handle so much of blood and they might disrupt. So preeclampsia, chronic hypertension, high age, they are the risk factors which are because of, they are the maternal risk factors causing abruption. Any kind of abdominal trauma. If the patient has myoma, if the patient already has, some patient tend to have subchorionic hemorrhage. आपको normal finding मिलेगी. कई बार ultrasound में subchorionic small hemorrhages does occur. As such, they are not worrisome, but they have a future risk of abruption. Fetal risk, multi-fetal gestation. So whenever there is multi-fetal gestation, then there is risk of abruption. Then if there is preterm pre-labor rupture of membrane, अगर membranes एकदम से rupture हो गए, if the membranes have ruptured abruptly, so as the fluid will come out abruptly because of this sudden decompression, uterus के अंदर क्या होगा? Negative pressure will be created, sudden decompression. As a result, placenta will get detached. बिकॉज प्लेसेंटा की एक साइड पे, जो दिस इज प्लेसेंटा की वन साइड पे प्रेशर हैज सडनली फॉलन, इट विल गेट डिटैच. So PPROM is a risk factor for abruption and hydramnios. So these are the risk factors for abruption. Certain behavioral risk factors very important: smoking and cocaine. These are very important risk factors, many times given in your question to indicate abruption. Okay? How the abruption patient will now present? Remember placenta previa kya tha? Bleeding, which is painless, which is causeless. Here there is bleeding but always there is pain. Because वो disrupt हो गया, normally situated placenta has disrupted and a clot is collected there. So there will be pain along with bleeding. And bleeding is generally dark colored because it is a collected blood. ठीक है? Then patient will have abdominal pain, patient will have back pain. So pain is very characteristic feature differentiating previa and abruption. ठीक है? Many times when abruption is there, by the time patient comes to you, by the time patient sees the blood, fetal heart is generally, it is not absent, but fetal heart is generally deteriorated. So by the time patient comes to you, 60% patients will have a non-reassuring fetal heart. Whereas in placenta previa, fetal heart is generally normal. Next, on examination, very important. When you do per abdomen examination, uterus will be tense. Uterus will be tender. Just opposite of previa. It will be tense, tender. You can also call it board-like rigidity. बिल्कुल rigid abdomen होगा. Board-like rigidity. Question might give you, because वो board की तरह rigid हो जाएगा, will you be able to feel the fetal parts? क्या आप fetal parts को feel कर पाओगे? Fetal parts are non-palpable. You will not be able to feel the fetal parts because it is rigid. A different scenario when question gives you, बहुत common question है that patient comes to you with bleeding, fetal parts are very easily palpable or fetal parts palpable in abdomen. Remember ये uterine rupture है. Fetal parts not palpable, तो ये मत सोचना क्यों? Because the uterus is rigid, so fetal parts are not palpable. Then on PV, remember in abruption we don't do PV. When patient has come to you with bleeding, we still don't know whether it is previa or not. जब भी placenta previa होता है, PV is not done. क्योंकि आपकी PV से वो placental tissue और bleed करेगा. So PV is not done unless you do the ultrasound and rule out previa. क्योंकि याद रखना placenta previa में PV नहीं की जाती. As soon as you see ultrasound of placenta previa, you don't do pervaginal. Abruption में भी, unless you have an ultrasound showing normal placenta, you don't do PV. ठीक है? It means, do we need ultrasound for diagnosis of abruption? No. Abruption ultrasound में दिखता नहीं है. So ultrasound is not needed for diagnosis of abruption. Remember, ultrasound is needed to rule out previa. अल्ट्रासाउंड में एब्रप्शन इज नॉट विजिबल. वाई? बिकॉज जो ब्लड क्लॉट है वो प्लेसेंटा जैसा ही दिखता है. सो यू कांट डिफरेंशिएट बिटवीन अ ब्लड क्लॉट एंड प्लेसेंटा. सो एब्रप्शन इज अ क्लिनिकल डायग्नोसिस. बट यू स्टिल नीड अल्ट्रासाउंड. वाई? बिकॉज देर इज वन मोर कंडीशन दैट प्रेजेंट्स विद ब्लीडिंग एंड दैट इज प्रीविया. एंड अगर प्रीविया है तो यू नो आप पीवी नहीं कर सकते. So it is very important to understand this कि abruption ultrasound पे visible नहीं होता है. Your ultrasound might show nothing is there. Normally situated placenta. You have to make a clinical judgment. When the patient has pain, bleeding, uterus is tense and rigid, it is abruption. ठीक है? हमने ultrasound क्यों किया? So that we can rule out previa and we don't do PV. Right? You also do some general examination since you don't know how much blood might have bled, how much blood might have been there. You will do BP, blood pressure and all these things. You will do a general examination. ठीक है? Diagnosis. So I told you diagnosis is very much clinical. Okay, ultrasound does not show you abruption. One investigation that can still show abruption is MRI. MRI is very sensitive for abruption. But generally you don't need that because clinical diagnosis is sufficient enough. So MRI is a very sensitive investigation for diagnosing abruption, but generally we don't need that much. Clinical diagnosis is sufficient enough. You always do ultrasound to rule out previa, always. Other than that, blood tests are very important. बिकॉज आपको पता है एब्रप्शन में द कंसील्ड हेमरेज माइट हैव अकर्ड. आपको जो दिख रहा है ब्लीडिंग दैट इज वेरी लेस, इट इज टिप ऑफ आइसबर्ग. ब्लीडिंग बहुत ज्यादा होगा ऊपर. सो यू ऑलवेज डू CBC. वन इंपॉर्टेंट थिंग, placental abruption is a risk factor for DIC. DIC placental abruption में बहुत कॉमन है. क्यों? क्योंकि जितना भी ब्लीडिंग हो रहा है दैट इज गेटिंग कलेक्टेड. इफ दिस इज प्लासेंटा इट इज गेटिंग कलेक्टेड रेट्रोप्लेसेंटली. सो थ्रोम्बोप्लास्टिन फ्रॉम दिस ब्लड लीक्स इनटू maternal blood. Thromboplastin release into maternal blood resulting in intravascular coagulation, universal coagulation in the blood, because of which DIC will happen. So you will get a coagulation profile of this patient. You will get D-dimers, fibrin degradation products to rule out DIC. You will also get kidney function test because acute renal failure does happen in abruption because there is so much blood loss. As a result, what happens? There is tubular necrosis that happens in the kidney. Because आपको blood loss दिख नहीं पा रहा, you are not able to judge it. That is why it is misdiagnosed. So acute renal failure and DIC are very common complication. That is why you need these tests. Okay. What are the complications we have discussed? DIC. Because of release of thromboplastin into maternal blood, there is coagulation everywhere, and all the as a result plasminogen is activated resulting in plasmin. ठीक है. All the consumption of all coagulation factor happens resulting in DIC. Then abruption is the most common cause of coagulopathy, most common cause of DIC in pregnancy. Other common causes of DIC in pregnancy are IUD, sepsis, amniotic fluid embolism. They are the other causes, but most common is abruption. Other risk factor is covular uterus. Many times when you do cesarean, you see this picture. Can you see hemorrhage in the muscles of the uterus? So when intramyometrial hemorrhage happens, that is covular uterus. इसे uterine apoplexy भी कहते हैं. So bleeding tends to get collect in the muscles of the uterus. Is it an indication for hysterectomy? No. There are chances that covular uterus might bleed too much due to atony, but you don't need to do hysterectomy. Once you deliver the baby, it will eventually get normal. Acute kidney injury and Sheehan syndrome. These are the complications that tend to happen in abruption. Why? Why in abruption? Why not placenta previa? Placenta previa mein all the bleeding is visible. There is no thromboplastin generation that can go into maternal blood. It is all coming out. So there is no DIC. And when you can see bleeding, you can manage it then and there. So there is no further complication. But whereas in abruption, you misjudge the amount of bleeding. Okay? Differential is one, that is placenta previa. But we know how to differentiate. Onset of symptom is sudden in placental abruption. It is generally anemia and shock of the patient is much more compared to the bleeding which is visible. Okay? Because bleeding is more internal. Pain is intense. Remember, pain is intense and acute, whereas placenta previa mein there is no pain. Uterus is firm and board-like in abruption. These are the differentiating features. Management. Placenta previa का management क्या था? मैं लिख देती हूँ so that you will not forget. Generally it subsides on its own. तो आप patient को term तक ले जाते हो and then you do LSCS. Abruption में patient progresses very well if you induce her. She progresses very well. So mode of delivery in abruption is always vaginal. First, she progresses well. दूसरा, you know there is risk of DIC. So a person who has a risk of DIC, you will not tend to do LSCS in her. So you always try to do vaginal delivery in abruption as soon as it is diagnosed. So आप conservative management abruption में नहीं करते हो. As soon as you diagnosed, you go for vaginal delivery in abruption. Only 2 contraindications for vaginal delivery. If the mother is in shock. Shock. I'm not saying mother has tachycardia. Mother को tachycardia होगा. उसको blood loss हुआ है. थोड़ी hypotensive होगी. It's okay. But if mother is in shock or there is fetal distress, these are the 2 indications where you will go for LSCS. Very important question. That has been asked previously in NEET. So if question mentions fetal distress or question mentions maternal shock, you will obviously go for cesarean. You will not wait for normal delivery. If this is not there, if the patient has bleeding, fetal heart is normal, mother is just tachycardic, or question writes mother is stable but abruption is there, what will you do? You will induce. You will always go for vaginal delivery. whereas in placenta previa you always go for cesarean. So this is all about abruption. If there is any doubt, do write in the comments.